Well, welcome here to this talk conversation, and I think it's going to be a very incredible conversation. It's about climate change and health equity, and some things that I don't think necessarily a lot of us think about. And I know, being in the news industry, we tend to focus on climate change, we tend to focus on health equity, but we don't tend to connect the two, and that's what we're going to talk about with the experts here, and we have a fantastic panel, so let me introduce them. To my left here, Vanessa Kerry. She's the Special Envoy for Climate Change and Health at the World Health Organization and the CEO of SEED Global Health. Vanessa?
Hi, good morning.
Good morning. Just introduce yourself to us for a couple minutes.
Hi, so I'm Vanessa Kerry. As he shared, I'm the WHO's Special Envoy for Climate Change and Health and the CEO of SEED Global Health. I'm also a physician. I'm a mother of 2 small children who are growing up in this increasingly turbulent world. And I've spent really 2 decades focusing on investing in health systems and the importance of strong health systems to deliver not only high-quality, equitable care to those that are most vulnerable, but really because stronger health systems means better health for all, which means stronger economic growth, which means better security, stronger communities, less political turmoil. There's a whole cascade across sectors that we don't even think about that are linked to our health and our well-being. And we, at SEED Global Health, we focus very much on training healthcare workers because we believe health workers, people, are the heart of a health system. And that when a woman is dying in childbirth from hemorrhage, it is a nurse who hangs the bag of blood. It is not a machine. It is not technology. It is not data. It is a human. It is a human that holds your hand when you are dying so that you do not die alone. And we know that people are on the front lines of the climate change crisis too. We see that all the time, and I'll look forward to sharing some of the stories and ways that we're seeing that in our work in sub-Saharan Africa.
Great. And to her left, Malama Tafuna'i. She is a primary care physician in Samoa. I've always called it Samoa, but found out when I met Malama it's Samoa. And she's a senior practice fellow at the University of Otago. Malama?
Greetings to the First Nations people, to your mountains, your rivers, your land, and to your ancestors. So I'm from Samoa, which is a small Pacific Island nation. We are a population of 200,000. I was born and raised there. I was educated, though, in New Zealand. I'm a medical doctor, and I've worked in New Zealand and in Samoa. I moved back to Samoa in 2010, where I work in rural communities on other islands. And in the last 7, 8 years, I've taken a journey into academia to actually learn how to articulate myself, to learn how to communicate the things that we deal with in the context of where I live and work. And so that's been a really exciting journey to be able to do that and to be here. Thank you.
And thank you for being here. Like I said yesterday, I think you get the award for traveling the most distance and time to get here. So it was quite the trip you told me about. And to her left at the end here, Rachel Levine. She's the Assistant Secretary for Health at HHS. Rachel?
Well, thank you very much. It's a pleasure to be here on this fantastic panel and to be with you today. So all you have to do is look at the headlines this morning to see the impacts of climate change on health. And that is extreme heat throughout the United States, but extreme heat throughout the world, with deaths recorded in the United States and throughout the world. And then with many other challenges, storms that are exacerbated by climate change, sea level rise, and forest fires, and the resulting smoke from forest fires, which are pretty common here, but not so common in Washington, D.C. and in New York City that we experienced last year. So in response to that, we have formed an office in my portfolio called an Office of Climate Change and Health Equity. And we want to emphasize the health equity component, because it's the same communities that have suffered health disparities from other causes in terms of the COVID-19 pandemic and the acute phase of the pandemic, in terms of other sexually transmitted infections, in terms of nutrition security, environmental justice, and more. So same communities that are suffering health disparities to climate change, and that's what we're aiming to address at HHS.
Fantastic. And one of the things we want to focus on is that health equity, or I would argue inequity, that's going on, especially when it comes to climate changes. And I think there's no better place to focus, at least initially, on the international spectrum here and what's going on. So, Malama, please give us a bit of a reality check on your daily life and work and how climate affects that.
Okay. I think at first I just want to say it's really interesting being here talking about health equity and climate change, because I think something that we're navigating is just understanding what equity is, and equity in the context of who we are in our culture, in the context of the resource constraints that we work under, but then also what a climate change lens is, because I didn't really know I worked in climate change until I started talking about the work I do, and I was told that, oh, you do climate change, and I said, no, I just do daily life. And so, yeah, climate change is happening, and I think because we're still trying to navigate a health system that we don't really understand. We work in a health system. Sorry, I just want to say that for us to talk about climate change, we need to talk about colonization. We need to talk about imperialism. We need to talk about coloniality, because they're not different for us. They're the same on how we try to address what's happening to us, how we're trying to understand what's happening to us. And I think what's happening in our everyday life, we don't identify it as climate change, because it's just what's happening in all that we do. Having trained in a Western health system, having trained and worked in the developed world and coming back home, what I'm seeing is what we've learned in textbooks isn't how diseases are presenting. We're not presenting the way we've been taught in a medical school, and then you come into the reality of our daily lives, and then there's that complexity of our cultural context of how we interpret the world and how we see the world, because we don't recognize illness sometimes. I still live in a culture where we see traditional healers, we go to traditional medicine before we go to the Western health system, and so we're still trying to unpack what climate change is on that. And I'm very fortunate, having worked in other places and then coming home, I can see these changes that I'm like, that's not what's in the textbook. There's another layer upon this that we need to try and understand and articulate what's happening. Did I answer that?
No, you did. That's fantastic. Thank you. And Rachel, in the context of that and the understanding of that, how do we show people that health has a role in climate change? Because again, I don't think people necessarily connect the dots, especially when it comes to equity and thinking, okay, there might be some populations that aren't as advantaged and that this is impacting them more.
So we have been having those discussions, and I think that health is finally at the table. So Secretary Becerra at HHS has a seat on the National Climate Task Force. There was Health Day in Dubai at COP28. And so I think that health is part of the discussion. But the way I think that we really emphasize this is by telling the stories of people that we meet and telling your story for your community. And so I'll give you an example. I had able to go to Alaska last summer, just about a year ago, and got way out of Anchorage into the northwest of Alaska to a number of rural Alaska Native communities who are being so impacted by climate change. So one in a town called Suvunga in the Bering Sea, their homes are literally falling into the permafrost. And so the permafrost is melting and their homes are falling into the permafrost. The Pacific fish are invading Arctic waters because of the warming of the Arctic waters. And the Pacific fish, Pacific cod and other, are starting to outcompete the Arctic fish. And that will change their food sources, but the food sources of the mammals that they depend upon, seals, walruses, and more. They go out and hunt on the when the water freezes, but they have to go twice as far to come to the ice pack. We are up in Utiavik, which is the northernest part of the United States and the top of the world, and significant changes in terms of the runs of caribou. And so most of the native tribes are subsistence livers, and so they have to hunt and catch fish for their livelihood and for food, especially throughout the winter. And all of that is changing and significantly changing their lives as they are impacted from climate change. I've been to other American Indian tribes. I was recently in the Navajo Nation with extreme heat and forest fires, also significantly impacted by climate change. I think it's going to be those stories that really demonstrate the impact of climate change on health as much as statistics and data.
And I agree. I think, we're seeing the movement in that direction. We're seeing a bit more understanding. But Vanessa, how do we challenge that status quo? Because that's still there.
Oh, it's my favorite question. The reality is, look, I think that is the right question, is how do we challenge the status quo? We are moving in a trajectory that is still not getting us in the right direction. If you just look at climate change, last year was the hottest year in history that we have ever had. We are already facing temperatures that are well above what is expected today, here and now. You just read the news, whether it's what's happening in the United States or what's happening around the world. Extreme heat is killing people across the board. That is just the direct impacts of extreme heat. What you're not reading about is the fact that 8 million people a year die from air pollution. That is more than in the entire COVID pandemic over the span of the pandemic. And the people who are dying are those that have the least amount of resources with which to respond and adapt. And so what we're actually doing is doubling down on the status quo. Speaking of colonialism, speaking of imperialism, speaking of the history that we live in this world, it has been that the rich nations have dominated how the world works. They dominate who gets the vaccine and who doesn't. They dominate who is producing fossil fuels and who is being most impacted but not producing. And we're dominating kind of how we're structuring our path forward. And those that are most vulnerable are those that have been the most vulnerable all the time. Sub-Saharan Africa, where Seed Global Health works, has 24% of the world's global burden of disease already. Only 3% of the world's healthcare workforce to address that disease, and is getting pummeled by climate change every day. And so we have to challenge the status quo. And I think how we do that matters immensely, and that's incumbent on all of us on this stage and all of you in the audience and everybody that we can bring into this movement. Climate change is fundamentally, actually, it's not about degrees Celsius. It's actually about the lives lost or the lives saved. Because that is what we're fighting for in climate change. And health is being impacted not just with extreme heat. We are seeing this in terms of rises in non-communicable disease, rises in mental health crises everywhere, rises in stillbirth, preterm birth, rises in vector-borne diseases, ticks, and dengue. We're seeing the rise in communicable diseases. In Malawi, where I work with Seed Global Health, they've had the largest and longest cholera outbreak ever in history because of a rise of tropical storms that have been hitting southern Africa. Zambia has a giant cholera outbreak that has happened. It's shutting down schools, shutting down businesses. So you're asking communities that are already suffering to figure out how to rise against these challenges even further. And it's just a feedback loop, a vicious cycle of poverty and poor health that is hard to escape unless we start to think very meaningfully. What we have to realize is that our health and well-being very directly relates actually to our economic endpoint. So if we think about the fact that the world today, if the driving force of the world is often what the economic bottom line is, great, let's talk about that. We're losing billions in productivity from extreme heat every year in this country, 100 billion right now. It's going to be 500 billion by 2050. The cost of people getting asthma and lost work days and not being able to go to work, or parents whose children end up in the emergency room, is millions within this country alone. So if we can think about ways to creatively demonstrate that we're losing on all fronts, not just the equity front, and that equity actually, we can help compel people, I think, to do the right thing, to have the moral public good, to get us to the place we need to go, but in terms and languages that everybody can understand. But make no mistake, we have got to challenge the status quo here and now, because what we're doing is not sustainable.
Taking a bit of a step back, you alluded to the definition, but what do we mean by climate change? This is for all three of you, because often people think climate change is just heat. You mentioned it's far beyond that. What do we mean by climate change and how it affects our health?
That's a huge question. Oh, sorry.
That is a huge question. So, I think that we are talking about the rise in temperature. As Vanessa said, 23 was the hottest year on record. It might very well be the coolest year that we ever see in our lifetimes. 23, and we're seeing more extreme heat in 24. But then all of the other changes that the increasing heat due to carbon dioxide and other carbon compounds in the air are exacerbating. So you talked about the impact upon air pollution, the impact upon extreme storms that are exacerbated by climate change. They're talking about we only have grade 5 hurricanes that we might need to actually get out of 6 for those. In terms of sea level rise, which I know impacts your country. And so all of those other impacts of climate change and quote-unquote global warming, I think are part of the whole climate change definition.
In my context, it's really, thank you for your sharing, because it's really interesting hearing you articulate the problem, because I think that's one of our problems. We don't know how to articulate it because we don't know how to research it. We're still at that stage of we need to do the research in our country to understand what it is we're seeing. Climate change, I sit and think about what happens at home, and there's the obvious things in natural disasters and the rising sea levels and the acidification of the sea, where our food biosecurity is really impacted. The foods that we eat now have changed, and that's causing illness. And one of the things that I find challenging as somebody who's indigenous is our connection to the land. I'm from a place where we take up a third of the world's surface, and yet there's only 1% of us that live there. We see ourselves as caretakers of this part of the world. We have a connection to the land and to the sea. It's genetic. You guys haven't found it, but something for you to do with all the resources you have. And that connection, we don't take it lightly. And one of the things that is really challenging is that in seeing, what I do like about talking about climate change is that in the space of health, it takes the focus off diseases and it puts the focus on people. Because if we can see what's happening to the people, we can be a little bit more patient-centered or people-centered, which I think is really important in this conversation, to take us back down to the communities and what's happening at the communities. We have natural disasters. These impact our food biosecurity. The changing weather is impacting it. We can't grow the crops that we used to grow, the fishing that we used to do. We can't catch the fish that we used to catch, so what we're eating is changing. Colonization plays a part in this because cash economy is huge. We're still challenged with how to engage with the cash economy. We're a small country. We don't have enough jobs for people, but we need money to survive, to send our kids to school, to get electricity, to have gas for our cars. And so because there's not enough jobs, one of the ways that we're dealing with this is that there are work schemes where people from Samoa can go over to New Zealand or Australia to work in agriculture industry. The people that go are able-bodied people. These are the people that we should be at home working in our agriculture, planting in our plantations. But no, they're overseas planting over there in their agriculture. So what's happening to our foods? Supply. We're not developing our food infrastructure. And so we're sitting at home waiting for the remittances, waiting to receive that, and then go to the shop and purchase canned foods and I don't know, anything else processed that we're eating now. Rice, we eat a lot of rice now, we eat a lot of meat. But I don't think we understand climate change enough to understand the impact of now us being so dependent on meat and the meat industry. I've only just learned about the meat industry in the last couple of years and looking at the impact of that. And I think as we start to understand more about climate change, hopefully we'll be a little bit more responsible, understanding our responsibility to caretake over the land and the sea.
We're in the 21st century, and I've heard this from more than one person, and I think there's a belief out there. AI and tech, is that going to save us with climate change and health equity?
So there's certainly a role for AI and tech, and AI can be a very powerful tool for, I think, creating equity if it is employed appropriately, and access to, and the questions we're feeding into the AI, right, are actually looking to solve equity issues. And I think so some of this is in, what we're asking it to do and how we're employing it, but there is without question a role for technology to cross difficult barriers, to be able to reach hard-to-reach places. With SEED, for example, we are actually a people-centric organization. So the punchline I would say about this is that there's a role for AI and tech, but again, you need people in the human interaction of healthcare and in just the dignity of who we are in our human relations. I mean, when you think about the fact, you look at folks who live their life in isolation versus folks who live their life in community and connection. People who live in community and connection have many metrics of happiness and other elements that make their lives whole, less mental health issues, things like that. So we're human, and everything we do in our lives is supposed to be about human connection. But we need to realize, again, that people matter in healthcare, and they're at the front lines of delivering interventions, of managing quality of care, and so you need people. That said, when Ebola hit in Uganda, and it was clear there was no vaccine available, and it was going to be able to spread throughout the country, Seed, using a tech platform, partnered with the Ministry of Health and Project ECHO to actually train 4,000 healthcare workers around the country in order to create a ring of healthcare workers ready to identify Ebola symptoms, triage people appropriately, and help prevent the spread. And so it's a combination of using technology to be able to expand your reach, but also, again, making sure that people are at the center and you're not replacing.
But we can't sit back complacent and saying, well, AI and tech's going to save us. We don't really have to do much.
We cannot. No, we cannot sit back complacent and think that tech is going to leapfrog us to the answers. We need to be very holistic in our thinking. And this is where, again, we go to the status quo. We have to move away from silver bullets. If you look at the global health world, and I worry this is going to happen in climate change too, if you look at the global health, we've spent billions over the last 40 years trying to solve big global health challenges. We've done it piecemeal. We've done it in silos. We've done it disease-focused. We've not really thought about the fact that we are living in a system and we need a certain threshold of investments in strong health systems, primary care systems. Turns out a family medicine doctor can take care of 80% of health problems in communities. A single individual can cover all that. The majority of those are being driven by climate change. So if we built strong health systems based on primary care and universal health coverage, you have not only your response to climate change and health, you have your pandemic preparedness, you have your maternal child health, you have your HIV, TB, malaria, you have your mental health screening, you have the ability to deliver a different quality of care. But it takes a different kind of thinking. It takes a understanding that silver bullets don't work. I can tell you, Seed's been doing the work we've done for 13 years. You might say that's a really long time. I think it's incredibly short, because in that time, we've trained 42,000 doctors, nurses, and midwives that are in service to over 76 million people in sub-Saharan Africa. I think that's a blink of an eye for what we've been able to accomplish. If we do more of that, we can answer some of these problems. We need all of it is the problem, and we need to have the courage to realize that we have the money in the world, we have the funding, we have the wherewithal. It's a decision. And the decision has to be that we're going to rise to this moment, and we're going to mobilize in a way that we haven't before. We're going to partner in ways, we're going to learn together in ways that we never have before. And it is very, very possible. We just have to choose to do it.
Yeah.
Well, thank you very much for all of those comments, and I agree completely. And so really what the Biden-Harris administration is working to do is to do exactly that. And so our Office of Climate Change and Health Equity is working with the White House, and we have something called a White House HHS Climate Pledge. And this is for the health sector writ large in the United States. The health sector accounts for 8.5% of U.S. carbon emissions. A tremendous amount of carbon emissions. And so we're not going to meet the president's goal of 50% carbon reduction by 2030 and net zero by 2050 without the health sector. So we are working with healthcare companies and health systems, but also pharma and those in the supply chain, which is critical, to follow the pledge and build resiliency to the impact of climate change, and to be 50% reductions by 2030 and again net zero by 2050. And we're working with those companies to pay for that with the Inflation Reduction Act. And so we have had a catalytic program working with many, many other companies with webinars and now technical assistance to accomplish just that, and to join the pledge and to learn how they can do this and get money from the IRA to accomplish this. I also want to highlight our work with the National Academy of Medicine and Dr. Victor Zhao, who was here at Aspen earlier this week, and I'm co-chair of that collaborative, working with more health systems to basically to get on board, to learn about how to do this, to educate healthcare providers throughout the United States to be able to do that as well, and to get on board to accomplish the goals we need to accomplish, both in resiliency and in terms of decarbonization.
Can I jump into that? Health systems. Thank you for bringing that up and building strong health systems, because that's a challenge for us where I come from, because we have a health system that was introduced that wasn't designed by us, it wasn't designed for us, and we're expected to navigate it, to use it to address the issues that are burdening our people right now. And it's interesting to hear you talk about developing that and building it, because I hope that we're part of that conversation, because it's the dominant health system in my country, and it's a health system that wasn't discussed with us. You know, nobody came and said, hey, this is a health system and it'll work for you. You know, it was imposed upon us, and after something really tragic that happened, the 1918 Spanish flu, where we lost a third of our population. And so it was introduced at a time where distrust was at the foundation of it. And so we, where we have our own traditional beliefs, our own traditional medicine, and our own traditional healers, there's a distrust for the health system, and we're trying to navigate it to work with them with that, and we don't see a lot of it, unfortunately, particularly in the I guess the support and the assistance it comes into the country. And so, and I guess part of it a fault on our part, we haven't got the skill set to articulate ourselves well, to engage, but also to take the recommendations and the advice given to actually contextualize it to our situation, to our culture, to I guess our way of life, to really work well with it.
I mean, I'm not surprised to hear you say that at all, because I think that's the case of many health systems around the world. When you look at history and colonialism and colonization and the way it has worked, health systems were created in a certain way. And in many parts of the world, too, health systems were destroyed because in the 1980s and the 1990s, external funders, the IMF, the World Bank, and others at the time thought that the way the world had to work was to pull back from social sector spending and worry more about market growth, and the market growth would generate funds that could then go back and take care of health systems. And what that did was begin to strip funding from a lot of these health systems, stripped from training healthcare workers, stripped from being able to build out health systems that are in service to people and designed by the people in a way that is contextual and understood. And I think there's real questions now, to your status quo point two, real questions now about how do we start to shift that and change that. And I think there's a lot of thought, and it comes from putting countries in the lead. Local communities that understand best the context of their problems, the solutions that have been tried, the solutions that can be sustained. And if you partner around that thinking and you think, how do we build from that viewpoint, you're going to build a stronger, more responsive health system, one that meets the problems of the moment and the future problems that are coming and are felt. And I think also can align funding from external sources in a way that is actually much more effective. It is still too common that donors set the agenda and say, this is the project we think should happen, here's the money, here's the timeline you're working with, here are the metrics you have to work towards. And that means that countries are bending over backwards to form-fit funding in a way that doesn't actually allow them to reach the most people, and to do metrics for this donor that are different than metrics for this donor. And we're wasting money, we're wasting time, and we're losing lives. And I think that the reality is, if we can start to get behind one single plan, one vision. The Minister of Health in Malawi has her One Health vision. Now she needs the funders to get behind it and to get behind the single metrics. And if we can do that, I think we can actually demonstrate a different path forward.
How do you get those funders?
Well, I think it's a couple things. One, there has to be capacity. I'm very, very intrigued to hear you say. You can't say it's... I struggle. It's no one's fault here, right? The question is, where are we today? And how do we get to where we need to go in the right way, and with honesty, and with a way that has integrity to rise to where we need to go? And that means building capacity at a really local level so that you can say, this is what we need. Rwanda's an excellent example.
No, and Rachel, the HHS can't do it by itself.
Well, HHS can't do it by itself, and we do have equities across the world, but we're not the primary funder across the world. The USAID would have the United States government's primary role for that. And HHS in the United States can't do it alone in terms of the federal government. It really is going to take coordination, collaboration, and cooperation among the private sector and the public sector. And it takes communities and states and the federal government working together, and us working together across the world to achieve this. So this can't just be a United States solution either, because it's one world. We talked about One Health, but it's also one world, and climate change and the other impacts that we're talking about are international and global. They're not just located in the United States. So we do have to take that bigger picture And I think the Biden-Harris administration has done that with, of course, Senator Kerry and now John Podesta and others trying to work across the world on that. And, of course, Vanessa's work and your fantastic work in your country.
On that light and looking at that, we talk about, getting the health equity and making sure that we're looking at other countries that aren't as developed. But how do we assure that equity on a global basis when part of what we're talking about is pulling back on industrialization a little bit? We've gone through our industrialization. Other countries are trying to go through theirs, and at the same time, there are people saying, we just need to stop things where they are right now. Number one, it's not fair for the countries that are still trying to struggle to get through that. How do we assure that global equity? Malama, I'm interested in your perspective on it. It's easy for us to say, stop doing this.
Yeah, it's really interesting. So the longer I've been in this game of health, and I've been a clinician for almost 30 years now, and when I got into it, I thought I was just going to be sitting in a clinic seeing patients and life would be good. I'm realizing
it's not the way
health is actually political. It is really political. And you have to learn how to engage with politicians. Now, Samoa, I may have said this earlier, two weeks ago, we celebrated our 62nd birthday. I think that's important because we're a peoples that have been in existence for over 3,000 years, and yet internationally we're 62 years old. What happened for us to be 62 years old? Colonization happened. What happened with colonization? And I don't want to talk about the losses in there around cultural identity, cultural practice, cultural knowledge. I want to talk about what was introduced. Western health systems in our education, our government, in our judiciary, in health. And that's what's challenging because, in my language, we have this word, maipalangi. It's a new word, newish, and it means illnesses that we associate with Europeans coming. And so, this is why we tend to go to the traditional healer first, because when things happen, when we recognize illness the way we understand what sickness is, we go to our traditional healers, but then, if the traditional healing doesn't work, then they'll come to the Western health system. It's really hard to articulate that on this level. Listening to all this, I actually really wish, I said this yesterday, I really wish these were my problems. And I wish, and I don't mean any disrespect by saying that, but I say that because some of the problems that I've heard being addressed at this conference, they're problems that you assume that there's this robust infrastructure lying underneath it. We don't have that. We're still trying to figure out what primary care is. We use that word. We love that word. We engage with donors with that word. Donors tell us that's the best thing for us, but we don't have the infrastructure that exists in the developed world, and I think that's what we need. And so I asked, what's equity? At home, we're just trying to get health. And then now we're putting in equity in it. But what does equity look like? Because somebody defined equity in the developed world and came and said, you need equity. Yes, I do. But what is it? Is it equity through my eyes, which is, I think I should have the same care you have in America? Or is it equity that's realistic for the resource constraints that we have just to get basic care, where I can just go and see a doctor and not have to pay out of pocket to just go and see them and not travel 4 hours, that kind of thing? I don't know.
I think it's a terrific question. I think the truth is, though, it's a little bit of both, right? Because the reality is we all do better if we are all healthy. And I think that we've discovered in COVID how deeply connected we are. It's not as though what's happening in remote countries from here don't implicate our lives. Maybe we can insulate ourselves more as we have the privilege of sitting here in Aspen and having these conversations and being able to think about these problems intellectually, where somebody is living them very real right now as we speak, and having the experience of not having enough food because of the drought in Zambia, and they don't know how they're going to feed their children, and that has lifelong implications for their child if you are you've malnutrition, and that's happening as we speak to children all over the place, right? We're starting that trajectory for them. And so I think we do have to think a little bit about how we are distributing resources across the world in general. and how we can do a better job to raise everybody up in more of a way. But you're also right that it is contextual. Malawi, for example, spends only $34 per capita on health because it's all it can afford. The basic minimum services that the WHO would recommend cost $76, per capita per year. And so there's already a discrepancy in that. So they're not even at what would be a global thing, and then they have inequities within their country. But I think there's maybe a secret in this too that we can use. What is equity? We need to define it. We need to understand it's about human rights and dignity and that we're treating everybody to have some access to fundamental needs that are happening in the world. But I think we also have to realize that, again, it's actually a fundamental way of living on this globe that makes us all better and stronger. It turns out that countries that have greater inequities within the countries actually have higher all-cause mortality in those countries. So even if you can close the equity gap within your own country, you can raise or lower the mortality rate within your country just by creating, some sense across your country on the whole. If we did that at a global level, though, I think that we start to take the pressure off migration, for example. Because it is very difficult to live in a country where you don't have the services you need. And in this world of social media and connection, you see how the rest of the world lives or pretends to live, because that's what social media is about. And it doesn't necessarily create a sense of common good. And so I think, again, the question for me always comes down to how do we motivate people to do the right thing, create the global public good, invest in that good, but we have to translate into a language that people understand and feel compelled by. But we're not going to be able to survive if we don't move in that way.
And we've already brought up a couple examples of migration and climate migration to begin with, of going from Samoa to New Zealand and Australia. You talk about migration as well, trying to get to the jobs that are out there, getting away from the areas that aren't quite as livable. How do we deal with that when it comes to health equity, especially here in the U.S., because we are having a huge migration problem?
We are, and we have significant health equity issues right here in the United States. And I had mentioned my visits to Alaska and to the Navajo Nation, but we have significant health equity issues, for example, in East St. Louis, where there's no grocery store in East St. Louis. Every time it rains, they have sewage that comes up in their yards and in their homes. And the lack of transportation, lack of housing. So all those same issues, actually, we still have right here in the United States. So health equity is really foundational to everything that we're trying to do at Health and Human Services, and that's why our office is Climate Change and Health Equity. But health equity is really part of every funding opportunity, every grant, every rule and regulation change, and that includes, for example, reproductive rights and reproductive health. It includes food and nutrition security, and more. And so you're right, there are tremendous issues in terms of migration, tremendous issues about health equity for the communities of color in the United States, particularly the Black African American community, the Hispanic Latino community, and the American Indian Alaska Native communities.
I want to open it up for questions here, if anybody has any questions. Are there any?
While we're waiting for questions, can I jump into
Yes.
the migration? So,
Wait, questions, just a second.
and then after, you're the first question over there. So, just the migration topic, I think is really interesting, because when I think about Pacific peoples and why we migrate, and 50, 60 years ago, we migrated for better opportunities, better education, those kind of things. I hear now about refugees, and usually when we watch the news where I'm from, it's about war-related refugees. One of the things around migration today for Pacific peoples is we're migrating because of climate change. Mm-hmm. We're moving not because we want to, because we have to. And so not for where I'm from, we're still good for a few hundred years, I think, on my island. But there are Pacific Island nations where they've been told they'll be underwater in 50 years. That migration isn't a simple migration because it comes with mental health issues. We're talking about physical health problems, but there are mental health issues around that. Mental health issues when you go into a new culture and you've got to adjust to that culture. Mental health issues, and I think that we talk about in Pacific circles where, we recognize in the Pacific the triple burden of disease with communicable diseases, non-communicable diseases, and climate change. But we now talk amongst ourselves, should we be pulling mental health out of NCDs and actually thinking about it on its own, because there's a mental health problem that we see is going to be a real burden in the Pacific space of when you lose your ancestral home, when you migrate and you don't know if you've got a home to go back to. And then you're asking yourself, are you going to be a peoples anymore? If you don't have your land, you know, are you still that person from that land? And we don't, you know, we talk about it, but we don't know how to think about it, how to navigate it, and to think about how do we prepare for that. So, yeah, I think migration is something I think we need to be talking a lot more about, and also being very mindful. I'm aware of the migration that happens into New Zealand and Australia from my side of the world, but I was just reading recently about Marshallese people from the Marshall Islands who are migrating into, I think it's Minnesota, I don't know, but somewhere here. And I was really interested to hear about that migration and the relationships that America has with Pacific Island nations, because they're allowed to migrate, but they're not allowed to become citizens. And so if you can't be a citizen, who are you? And that's a really important question for people who are indigenous people.
Right.
But yeah, so.
Yeah, it does make a lot of
question.
sense.
Excellent point.
We had a question back here?
Yeah, hi, my name is Jason, and I've had the honor of living in the Middle East for the last 14 years. And one of the issues that I see is just meeting with ambassadors and specific donors. There's a lot of donor fatigue. And one of the things that we're working on right now with Gaza is provision of prosthetics for the 8,000 people who need them. And access is an issue, and that's political. But the question I have is, how do we humbly have an honest discussion about some of these challenges? I think sometimes people live a little bit in silos, and they don't get the honest reality of the truth on the ground.
I think so. I think one, stories, right? Being able to really bring the narrative from the voices of the people who are impacted make a big difference. I was sharing Malama. I always feel a little awkward as a North American woman who runs an organization that works primarily in sub-Saharan Africa, because I'm not living that day to day. So I prefer when, you know, Irene Atuherwe, our director from Uganda, is the one speaking on stage. And we made sure she was the one at COP28 who was actually telling the story of what's happening in her country. But I think if you can help highlight, at least bring the voice forward and the narratives of what the impact really looks like, I think that can be very helpful, because it makes it more real. It puts a personal face to the experience in a way that sometimes makes it different than when you're talking, you know, about 1.2 billion climate migrants by 2050, right? What does that mean? Where are they coming from? But you tell the story. I also think donors need to understand that we have a funding gap right now about what needs to happen in the world. So the gap, for example, for climate, you know, right now in climate and health, for example, that nexus, only about 6% of all adaptation funding is going towards the climate and health, building health systems, responding to the changes that are happening in our world today, and 0.5% of all climate funding is going to health, right? That's a problem when we need billions of dollars to close that gap. So I think funders can be overwhelmed by that, but actually you can have very meaningful, you know, very, very meaningful engagements with just a little bit of money. If you target it well, you're building the capacity and you're thinking about what the long-term outcome can be, and you can help tell that story too. I also think we have to realize, though, that philanthropy and funders can close that gap so that we can pilot things, we can demonstrate impact, and then take it to our colleagues at USAID or our colleagues at the World Bank or our colleagues that can mobilize billions. And if we can show how you actually save money, rebuild livelihoods, and that becomes a savings loop, you might actually get the corporate sector to come into it, because suddenly they see their workforce being protected and they see the ways that they're going to gain and win. So I think we have to get creative about how we make these links. We also have to be relentless, right? We have to demand something different, and we cannot give up, as exhausting as it is. And while that fatigue is out there, we have to close these funding gaps, because we're not going to make things move without the funding that can build the health system or help you understand what the definition of primary care is, or put the prosthetics to rebuild so that people can go to work or take care of their children or do those things. And so I think telling stories, I think thinking differently about the metrics of what the impact are that maybe break out of the health sector too will let people do it. And I think just being relentless and unapologetic. There is no such thing as too ambitious for the moment that we're in right now. And so I just encourage you to keep doing it, and thank you for being out there.
Oh, can I share into that
Yes.
question? Thank you for the question, Annie, because I feel like I'm on the other side of it, but it's the same side you're on, and new to that space as well. And I absolutely agree with you, because one of the things when I'm engaging with funders is I feel like I need to tell my story, but I also feel like the funder he's got to listen to my story as well, because sometimes they don't. And just something I wanted to put into that space is to tell our stories, but then don't be afraid to say no. Because the rules, like you were talking, the rules or criteria that come with the funding, sometimes it's not worth it. And I always feel like if you don't want to hear my story, if you don't want to be a part of my story, and then I don't want your funding.
Keep the authenticity. I love that. Very true.
Another question back there?
Hi, thank you all for your time today. My question, Dr. Levine, what are we in the United States learning from global health initiatives such as Seed Global with Dr. Kerry about closing health equity gaps here, where we have 30-year life expectancy differences in the same city in some locations? I'm in Texas. Dr. Tafuna'i,
Lama.
Unfortunately, we have a huge disparity in access to care and the issues that impact health in the United States. And it concerns me not only for our current citizens, but our future immigrants that come in, that they are going to suffer the same way our current citizens are suffering.
Well, thank you for that question. So we certainly want to learn from the fantastic work being done abroad and other great work that's being done right here in the United States. And so, as I mentioned, health equity is fundamental to everything that we're doing under our secretary for everything that we're doing at HHS. And so all of the different alphabet soup of divisions are really leaning in terms of health equity in terms of their work. So I'll highlight the work that HRSA does, the Health Resources Service Administration, and the work they do with our great community health centers, and the work that they're doing to service communities that have not had access to health care. The Indian Health Service that I've had the opportunity to visit, many of our United States Public Health Service and Mission Corps officers. We have 1,500 officers that work in the Indian Health Service, and the work that they're doing in Alaska and throughout the United States as well. We, for example, in Hawaii, our officers were serving to provide mental health care for the citizens of Maui after the horrific fires that occurred. The work that CMS is doing. So Administrator Chiquita Brooks-Lachure was here and talking only this morning about the work that CMS is doing, emphasizing access to care and reimbursement to care through Medicaid, through Medicare, through the marketplace, and then, of course, for CHIP for kids. So we are particularly trying to address all of these issues with all of our different divisions, and we're working particularly, as I said, for those communities that have suffered health disparities, and this is disparities of historical inequities, including that of systemic racism. So there's a lot of work to do. The work is endless. We need to continue to, as you were saying, to be persistent and relentless, and to continue that work now and continue that work in the future.
Any questions back here?
Hi, my name is Jamie Clark, and I invest in climate tech startups, especially ones that intersect with health. You all talked a lot about migration, especially how they're leaving because there are no more jobs. So my question is, what types of innovations and solutions are exciting to you to keep people at home, to create jobs, and what types of technologies should we be looking at and investing in?
I would love to see investment in helping us regain our traditional knowledge, something that we're losing. Thank you for the question. Yeah, so every time I go to conversations where we talk about innovations and like talk about AI, I'm excited about AI. I work in a space where I'm developing e-learning in Pacific Health, which is basically looking at migrant health. But when I think about home, I work with an NGO at home that works in rural communities, and they work to help women and their families find something that they can do around traditional knowledge, traditional practice to stay at home, and they find markets for this. And then they market their product, and it's usually around organic farming and around weaving our traditional fine mats, which is like a currency where I come from. I think sometimes when we talk about innovation, we think about, gosh, what's the new job in the town, or some kind of occupation that aligns with I guess, civilization. I don't know if I'm using the right words, but things that are new that look like what we see on TV that we want, or see in movies we want. But I think important for indigenous cultures, we're losing our traditional knowledge, we're losing traditional practices, and we don't know how to get it back because we're still struggling to try and figure out how to live in today's world and get cash so that we can put our kids into school and buy food and gas and all that kind of thing. So if there was investments to help us just help our communities stay at home and learn our traditional knowledge again so that we can do agriculture the way we used to do it before. We were told that you had to cut down all the trees and plant lots of food for lots of people instead of growing food in amongst the trees that we used to do. Little things like that, and the traditional knowledge in some of our weaving and how we used to catch fish. When we speak, in our language back home, we speak in metaphors, and a lot of these metaphors relate to cultural practices. And when I go into the village, sometimes I've lived in town for too long, because when I go into the villages and I hear people talk, and especially our chiefs, they talk, and sometimes when I translate it literally, I'm just like, why are the chiefs talking about pigeons, catching pigeons? And I'll be told, no, the way that they've described this situation going on in the village, they've used the analogy of what was happening for catching pigeons, back in the day. But we don't see that practice anymore, that it's really hard now for the young people coming up to understand those analogies again. So, if there was a way that our people could stay home and learn these cultural practices again and still be able to earn money and engage with the cash economy, I think that would be really helpful.
Great. And unfortunately, as always, we don't have enough time for any of this. So I just want to ask one last question, and if I could just get 10-second response from each one of you, just to end on an up note, hopefully. Is there hope?
100% there's hope. I am a diehard optimist, and the reality is we have all the tools we need. We have the knowledge. We know the problems we have to solve. It's a question of choice and making the right choice. And I think that the writing is on the wall in a way now that we are starting to see a change and a shift in decisions and focus. And I think there's nothing but excitement, but we got to create it.
Malama?
Yes, hope, because thank you for inviting me. I never knew Aspen existed or that this festival existed. So just to be invited to come here and share, but also that you guys came and you're listening. So yeah, I think there's hope, and I look forward to see what comes out of this.
Absolutely. So I always remain a positive and optimistic future, and I choose to be positive and optimistic so that we can work towards that hopeful future. And in regards to climate and health, climate solutions are health solutions. And so I think that they're integrally related together, and working together, I think we'll be successful.
Great. Thank you guys very much. I appreciate it.
Thank you. Thank you. Thank you so much. That was really lovely.